Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hello and welcome to the ASC podcast. I'm Bill Prentice, ASCA CEO. In a moment, I'll be joined by my colleague, Prentice Newbury, ASCA's Chief Advocacy Officer, to talk about some of the public policy issues that ASCA is prioritizing for 2025. But before we begin, I'd like to say a few words about how we arrive at our policy priorities each year. ASCA has 9 standing committees comprised of member volunteers and ASCA board members that meet throughout the year. And these committees work on improving our advocacy, our membership, educational offerings, financial management, and more. So with respect to our advocacy work before the Congress and government agencies, ASCA's Government Affairs Committee has the lead responsibility for identifying the public policy issues of primary concern to our members. And this committee is made up of 14 ASCA member volunteers. While it's obviously still early in the process, we believe that ASC should be well positioned in Washington in the coming year as lawmakers and the administration look for ways to reduce both spending and burdensome regulations. Even a small improvement in the way that the Centers for Medicare and Medicaid Services, or CMS, would reimburse ASCs could lead to a reduction in overall spending, since it would encourage the migration of procedures away from the more expensive hospital outpatient setting. And adding additional codes to the ASC Covered Procedures List would also produce considerable savings for the Medicare program. So then, we are writing the leadership at CMS this week to offer our recommendations for lowering costs and eliminating several ASC-related regulations that we believe add substantial costs to the system, but provide no measurable benefit to our patients. So with that background and introduction, Kara, welcome to the podcast.
Thanks for having me, Bill.
So Kara, in our letter, we addressed 3 distinct topics: CMS payment policies, the ASC Covered Procedures List, and the ASC Quality Reporting Program. And I'd also mentioned the full text of the letter will be available on the ASCA website. So let's go through these categories and explain our policy recommendations. Can you start with briefly explaining the payment policies that we would like to see continued or changed and why?
Absolutely, Bill. So I hope that most of our listeners are aware that for the past several years, ASC reimbursement updates have been based on the hospital market basket instead of the consumer price index for all urban consumers. So the first Trump administration established that as our update starting in 2019. It was supposed to be a 5-year trial, but due to a lack of data because of the COVID-19 pandemic, it was extended for an additional 2 years. But we are slated to come off of the hospital market basket as our update in 2026, unless the administration decides to keep us on it. So that is our, a number one concern regarding reimbursement. And in this comment, in this letter to CMS, is that we would like to remain on the hospital market basket indefinitely. It is historically a better update for a higher update, in addition to the fact that since our payment system is aligned with the hospital outpatient payment system, it makes sense for us to both be receiving the same update.
And that makes a lot of sense. And that's obviously something that the prior Trump administration started that pilot. So we would imagine they'd be pretty receptive to this.
That's our hope. And that's why we're trying to get this letter out to them prior to rulemaking, which is somewhat out of the scope of what ASCA has normally done in terms of our advocacy. But we really wanted to get out in front of this at the start of the administration.
Got it. And there's a second bigger ask that we have that I think is also a very common sense solution that would help produce savings, and that's the weight scaler. Can you tell us more about that?
We could talk for probably a few hours about this, as you know, Bill, but the general overview is the fact that CMS applies what they call a weight scaler to payment systems in an effort to maintain budget neutrality year over year. So absent the small inflationary update that we receive, CMS is trying to maintain the payment that they output in a given year. And so ASCs actually get 2 weight scalers since, as we talked about, our payment system is aligned with the hospital outpatient departments. There's the first one that's applied when those rates are calculated, and then a second ASC weight scaler, which we believe is actually not authorized by the Social Security Act. And so we've long been asking for CMS to stop applying a second weight scaler. It was only supposed to be applied the first year that our payment system was aligned with hospital outpatient departments. And so that will be something that we really focus on and try to get removed with the new administration.
Right. And just like the hospital market basket, we believe that if our reimbursements could be a little bit better and fairer, it's going to incentivize our members to take more Medicare volume that would shift from the more expensive setting. There again, producing the savings that this administration obviously is very hungry for so that they could spend that money in other places.
And we're already seeing that, Bill. One of the points that we raised in our comment letter is the fact that even for cataract, 66984 is the primary CPT code. We have seen a shift in volume to the ASC setting away from the hospital outpatient department setting. There wasn't a whole lot of margin with that code to begin with, but we did see an uptick in volume, and we believe that that is at least due in part to use of the hospital market basket. And we think that we would see bigger shifts on more procedures if CMS were to make the weight scaler change that we have requested.
Great. And I know we could keep talking about this issue for a while longer, but we have two other topics we want to cover. But before we do that, we need to take a very short break to hear a few words from our podcast sponsor. Please stand by and we'll be right back.
This recording of the Ambulatory Surgery Center Association is being brought to you by Surgery Partners, a leading operator of surgical facilities and ancillary services with more than 200 locations in 33 states. Surgery Partners offers multiple types of healthcare services that deliver high-quality healthcare in a convenient and cost-effective manner. To learn more, visit surgerypartners.com.
So, Kara, let's now talk about the ASC Covered Procedures List. We're asking the new administration to both reform the process for requesting the addition of new procedures and for CMS to approve several prior requests for additional codes that we know are being safely performed on commercially insured patients. Can you talk about those issues?
Absolutely. So, once again, during the first Trump administration, this idea was floated out there to have a clearer mechanism, a more transparent process for submitting procedures for consideration for addition to the ASC Covered Procedure List. It was actually a policy that was adopted under the Biden administration and now will continue. And so there's a new portal through the CMS website, the MIRIS portal, where interested parties can submit codes for consideration. You can enter the CPT code, you can attach additional documentation in terms of outcomes data if you have it, if we have research or studies, which we do for some of the procedures we're requesting. And it's really just a more transparent process. You can see that your requests were submitted. Where it fell flat is that CMS is not required then to publish the list of codes that are requested. In the Code of Federal Regulations, it actually says that they're only required to publish them if they choose to add them, which, is kind of silly. And so what we're requesting is that CMS, people have gone to the effort of, submitting, and we think that CMS should at least list all of the procedures that have been requested in the proposed rule so that interested parties can see all the procedures that have been requested. And then, of course, we would like the code that we've asked for to be added. So ASCA plans on submitting through the MIRIS portal spine codes. So a couple of lumbar fusion, 22630 and 22633, which we've long requested CMS add to our list, as well as some cardiology codes. Specifically, cardiac ablation have been requested by our members. We've been working closely with the national cardiovascular groups on that. We're all in alignment trying to get these procedures added. So we're optimistic that with the new administration that we might gain some traction, especially since those of you who were around might remember that the Trump administration the first time added a lot of procedures to the ASC Covered Procedure List in the last year that it controlled the rulemaking. And then a lot of those were reversed the following year. So there was an interest in allowing for more clinical discretion and adding a lot more codes to the ASC Covered Procedure List. But, first and foremost, we would just like some more transparency so that when CMS says that they do not want to add a code, they tell us why so that we can try to counter that with facts, with data that we have to prove that these are safe to be performed in the ASC.
Yeah, that last part is critically important because otherwise then we really have, the clinicians have no way of knowing where they fell short in terms of the data they provided to the agency. So I really hope that the administration sees the value in doing that. So Karen, the last category we have of the three in this letter is talking about our ASC Quality Reporting Program. And before I have you walk through our recommended changes, I think it bears mentioning that the ASC community really supports the concept of quality reporting, and we've long advocated for making these reports more accessible and more useful for patients. That said, what changes to the program are we requesting?
Absolutely. And Bill, I know you and I have spoken at length on this topic with each other, but the program should have two main goals. And that is to, help the patient have a better understanding of the quality of care being provided in a site of service and to help that facility know where they stand and how they may be able to improve. And if measures are being added that don't meet one or both of those objectives, then we think that they're falling flat. And so one measure that we have opposed since the very beginning when it was first proposed is the COVID-19 vaccination status of healthcare personnel measure. And we are optimistic that the Trump administration will remove that measure in the future, but that is a top priority for us regarding the ASC Quality Reporting Program. And so that's number one. We've asked for some more time with certain measures. I took it out of the comment letter because it was getting too long. But when we meet with CMS in person, we will be talking to them about the new total joint measure where you have to report on a bunch of different domains and criteria, both pre and post-operatively, do surveys to gain a better understanding of how the patient feels like they have benefited from the surgery. But that actually went into place on a voluntary basis starting back in October without any clear guidance for ASCs on how we're supposed to implement it because it's a measure that was never tested in the ASC setting. And all the guidance that is out there now is for inpatient hospitals, actually. And then all of the new health equity measures. I know based on my review of ASCA Connect, there's a lot of questions and confusion about the new health equity measures. And our primary concern, once again, is that none of these measures were tested for the ASC setting. And so it's clear if you look at the document that all CMS did was take the hospital attestation. They took out the word hospital and plugged in facility every time the word hospital was used. So we don't think that that's an appropriate or adequate way to convert a hospital measure into a measure for other sites of service. So, we're going to push back on that and the other health equity measures until such time as those are tested in the ASC setting.
That's great to hear, and I'm sure our members are very pleased for us to take up the standard and make that fight for them, because I really feel like our quality reporting program has really gone sideways because of all these additional measures that haven't been tested in our setting, may not be appropriate for our setting. So again, I think we're both hopeful that this administration will be more mindful of our concerns and hopefully will pare back a lot of this additional regulation. So, Karen, before we conclude, I want to mention one additional topic that we could probably talk about for an hour if we had it, but we don't, that not included in our letter, but is I'm sure in the minds of some of our members because it's coming up a lot. And that's the discussions that we've heard in Congress and in some states about a payment policy concept that is referred to as site neutrality, which essentially argues for having one across-the-board payment for procedures regardless of the setting, whether it's the hospital, HOPD, surgery center, or physician office. At the extreme, some have even suggested that site-neutral payment would be at that lowest, probably physician office rate, which would obviously be devastating for both hospitals and ASCs that perform many, if not most, of some of these procedures. Amy, can you tell us about these discussions?
So not only at the federal level, Bill, but now even at the state level, we're hearing site neutrality being discussed heavily. And at the federal level, to your earlier statement, what's being discussed is looking at where the most volume is performed and dropping everybody else to that site of service. So for instance, if the most volume was done at the ASC, the hospital outpatient department rates would drop to the ASC. If the most volume was being done at the physician office, everybody drops, the hospital outpatient departments and the ASC. So I think sometimes our members hear the term site neutrality and they get excited because they think that we're going to meet in the middle, that there's going to be some new reimbursement rate between hospital outpatient departments and ASCs, and we're all going to get the same thing. And that's not what's being discussed at all. So ASCA has tried to talk to the committees that have jurisdiction over ASC policy and try to talk to members of Congress who are interested in this topic and just try to explain to them how it's a much more nuanced issue than maybe it's getting credit for right now, be in the same boat where they stop performing these procedures. In addition to the fact, of course, that if we're talking about redirecting all this care to the physician office, it's unclear that there is the capacity in some areas for physicians to handle this volume, or they might not even be equipped to do these procedures. And we stand ready to work with both sides of the aisle to ensure that any site-neutral policies would not negatively impact our members.
Well, I'm sure our members are gratified to hear that because, a site-neutral policy makes sense financially. It would certainly save money. But I think that the problem is you've kind of laid out, it would create enormous access problems and also lead to substandard care probably for many patients with high risk that would be seen in a site of service that really can't protect them. So hopefully our policymakers will think long and hard before trying to move forward with a policy like that. Well, Kara, thank you for leading our advocacy efforts for the surgery centers. And I also want to thank the team we have that supports you, our board members and the volunteers like our Government Affairs Committee who make substantial contributions to formulating these policy recommendations. So again, thanks very much for your hard work.
Absolutely. Thanks, Phil.
So before concluding, I would also to acknowledge the support of our podcast sponsor, Surgery Partners, a leading operator of surgery facilities and ancillary services with more than 200 locations in 33 states. Surgery Partners offers multiple types of healthcare services that deliver high-quality healthcare in a convenient and cost-effective manner. To learn more about them, visit surgerypartners.com.